Okay, good morning. Welcome to today's webinar, and thank you everyone for joining us. This is module number 2 of the Employer Oncology Roundtable session, Diagnosis, Treatment Planning, and Care for Cancer Patients. We are putting this on as part of a grant through the National Alliance of Healthcare Purchaser Coalitions, Driving Innovation, Health, and Value. This is our parent organization. So LVBCH is a member of the National Alliance, as well as about 40 to 50 other coalitions nationally. And we were one of about 5 or 6 that were selected for this grant. I'm Amanda Green. I'm Director of Operations with the coalition. I'm also a health educator and registered nurse by background. I'll be helping guide us through some of the content from the National Alliance. And I'm joined today by our expert panelists. We have Dr. Wendling from Lehigh Valley Health Network, Dr. Wilson from St. Luke's University Health Network, and Elliot Codner from Genentech. I'll give them a few minutes to introduce themselves when we start with the content, but for right now, we're just going to get through some of the background material. So we're here today to talk about oncology. It is a top concern of employers. It's a huge cost, which we're going to get into a little bit more. It's a very complex disease. It affects many different systems, and it really does impact all aspects of patients' lives. I think any of us who have known cancer patients also know that it affects our families, caregivers, communities. So it's a big concern that affects a lot of people involved with diagnosis of cancer. So it's also something that is a little bit harder than other conditions to implement our traditional cost containment strategies. It's something that is continually more expensive. There's a lot of challenges and issues figuring out how to best play that. A lot of times employers don't want to come between cancer patients and the potential treatments that they want to receive, but still employers do have a large role in figuring out how to address this. So a little bit more about this specific roundtable. Again, we mentioned the National Alliance before, and in 2019, they released a report, Achieving Value in Cancer Care. It really focused on the education and the roles that employers can play as purchasers of healthcare. And from that, they developed these learning modules and put out the grant. The grant is also sponsored by Genentech at the national level, as well as the Cancer Society. So the curriculum here is really developed to help employers ask the right questions, incorporate oncology strategies as part of their overall healthcare strategy. And we're going to get into a lot of different ones in this specific area. So the module looks at the entire patient journey, going from pre-diagnosis through surveillance and survivorship. If you were able to join module 1, that was really focused on the screenings, prevention, pre-diagnosis, and the preliminary diagnosis. It's divided into 3, so you'll see here how they are. Again, prevention and the preliminary diagnosis were covered in module 1. Today, we're going to talk about diagnosis, treatment planning, and care. And module 3 is survivorship, surveillance, and back to work. And throughout them, it really highlights the support that patients and their caregivers need throughout this journey. So today is module 2. You'll see here that there's 6 identified action steps for employers and really highlighting in on this diagnosis and treatment plan section, along with some additional testing, second opinions, and again, really highlighting the importance of support across the entire journey. Again, our agenda is based on those action steps. So we're going to talk about support, confirming diagnosis, second opinions, network selection, treatment, biomarker testing, disparities, prior authorization. So we've got a packed agenda, but the idea here is to make it as engaging as possible. So you will see pop-ups come on the screen from time to time. We'll be doing polls. We'd also like to encourage everyone to ask questions using Q&A. You can also submit comments in the Q&A or chat feature. And this is just really meant to share. Throughout, our panel will be reacting to the content provided here, and we also want them to be able to interact with you, the audience. So these are just some terminology that was introduced in Module 1 a lot about support services. These are going to be highlighted throughout the content we're doing today, and there is a glossary that will be provided. It's at the end of the presentation and they'll be available for you online. So a little bit of background about our own LVBCH oncology statistics. And before we get to that, we are going to try our first poll. So you should have it popping up on your screen, and it is just about your employer size. This just helps our panel get to know you a little bit more. So can my other panelists, can you see the responses as they're popping up? Okay. I'm going to give it just another minute. If you haven't answered yet, please do. Can you see it in share results? Can everyone see the results now? Great. So a lot of our audience here is under 500 in size, and we do have a couple in the almost 1,000 and the 1,000 to 5,000 ranges also have a couple. So that's just a little hello to our audience to know who's on and about your employer size. We're going to go to our second one about healthcare spend. And again, that should be popping up for our audience. This is what % of your organization's healthcare spend is related to cancer care and treatment. And this is a little like, do we know? And there is an onshore don't know if you're not sure. I'm going to share the results. So most of our group doesn't know exactly what your cancer care spend is, and that is not surprising. So we're going to talk about some of the information there to help you work with your health plans and learn this information. And we're just using these as a primer for getting into our LVBCH statistics. One last one right now. So thanks for doing these just as a little warm up here. So this is about your oncology trend. And it's pretty much asking, do you know if it's increasing, decreasing, staying about the same, or onshore don't know? And again, we're just going to take another 4 or 5 seconds here. So again, we have a group that doesn't know. For a lot, it's also staying the same. We have someone saying it's increasing. So we're going to get into our LVBCH statistics, and then I'm going to go to our panel for some feedback. So this is based on the medical spend of the LVBCH. We can see it makes up about 11.5% of the overall medical spend. It is actually just slightly less than the norm. So the national norm is about 12%. We've actually had a decrease in the number of members. So our norm is about 2.9, and we were at 3.2. We decreased from just a little over 3% of members with a cancer diagnosis. I will share that this is the data from pre-pandemic, so 2019 data. We'll talk a little bit in this session, but more in the next session about the impact of COVID. And we have our top 10 conditions. Among them, the top 5 tend to be breast, prostate, colorectal, lung, and skin. So these are pretty common cancers that are the biggest spend. We also have a little bit about the pharmacy spend. So it is our number 3 condition group by cost. The trend is increasing there also. And for pharmacy, it's about 7% of the trend. So we're seeing for the group, in that 10% range, probably when you take medical and pharmacy. For our panelists, does any of this surprise you? Is this about what you would expect to see?
Yeah, I would say, yeah, I'm not necessarily surprised by this. I mean, I think I'm a little surprised by the rank of cost. However, there are a few, agents that absolutely are driving it. I guess from a dollar standpoint, but still the frequency is, especially in this employee population is relatively low as opposed to a Medicare population.
Dr. Wendling, did you want to add?
Yeah, I guess, a couple of comments. One is, I think in the pharmacy space, I would imagine that while it's ranked number third, it's probably one of the fastest rising proportionate rates of spend. It's also an area where there's probably a fair bit of opportunity to optimize that. And last, when we look at episodes of care, which is what is defining, these buckets, sometimes when you look at them, they put cancer in the sort of anatomic region of the body. So when you look at aggregated data, sometimes it doesn't give cancer enough episodes. So it might actually be, depending on how they cut your data, might be understating actual prevalence. That's a possibility, because we see that a lot when we really QA the data closely. So things like unusual lung cancers and GI cancers and things like that often get put into their so a GI cancer would get lumped into gastrointestinal, for example.
Great, thank you. I think that'll definitely come up again later too when we talk about kind of complex and rare cancers. And you're right that there's not really a delineating line always in the data that we have access to. Okay, thank you. So we're going to kind of jump into the content here. Again, we were just doing some warm up and some background on our own numbers here at the Coalition. So the first thing we're really going to talk about, it goes across the whole cancer journey. It's tying in from the first session. It's going to go across the third session. It's all about the need for support. So one of the first things that they kind of recommend is that programs should be doing these psychosocial distress screenings. They should have a policy and a procedure for them. They should be identifying the factors shown here. So psychological, social, financial, behavioral. These are all things that could interfere with the patient's treatment plan or lead them to have adverse outcomes. So we really want to be supporting them as much as possible. Did you want to talk about what either of the hospitals do to help with these types of screenings? Do you have policies and procedures in place or specific assessments that you do? Dr. Wilson, do you want to start?
Sure. Thank you for the opportunity to be here. I'm happy to participate. Yeah, so we have something that's called the distress thermometer that's given at the visit. It's not usually the first visit, since some of them are just like initial visits and they don't follow back up. But it's, we give it at the time where we're doing final diagnosis, treatment planning, and kind of assess what patients' needs are. And then it helps us, track it over time, see how they're doing over their their course, their cancer course, as well as identify, do we need to see, should they see palliative care? Should they all see our financial counselors, to discuss everything, and then, whether or not we need social work to get involved. But I think it's a nice measure to figure out sort of like where patients are, where their families are, and the needs that they have, and how best we can serve them through their journey.
Thank you. Dr. Wendling?
Yeah, it's going to sound very familiar and similar to what Dr. Wilson said. So at the first visit for, I'd say 90% of our cancers, they see really a multidisciplinary team. Before they see the team, they go through a really elaborate screening that includes, psychological, sort of all the social determinants of health, travel, ability to health literacy level, things like that, financial, food access, and any particular needs that they have relative to their treatment, family member assessment, their involvement, what their support system looks like. It's a very, very elaborate social, evaluation. And, it actually allows for us to look at the population in that way, which is also really important. So when we're looking at how to improve, say, breast cancer, we also have a lot of other variables that we're looking at that actually do have an impact on the treatments and the outcomes very, very significantly. So I think this is a really big advance forward because anyone who's treated complex illness knows that anything related to psychosocial distress is a huge, huge component to how well their outcomes are, how much is spent on them, and certainly their long-term outcomes. So this is a huge, huge, huge area and a huge area for optimization.
Great, thank you. I think that's actually a good lead-in as we go into the next piece of content, just in how far we've come. This is a report back from just 2016, so maybe 5 years ago. And what they found at the time, this is certainly more nationwide. I think we should all be thrilled to have such great health systems locally that take such good care of our patients. But in a nationwide cancer patient survey, they found that less than half were asked if they were feeling distressed by cancer or the treatment. Despite knowing the prevalence of emotional and financial distress, they weren't really making many referrals to counseling services or other professional services. And also that people of lower socioeconomic status, people of color also, were less likely to get optimal treatment. We're actually going to talk a lot about disparities at the end and the importance of that in cancer care, but that's a part that's going to come up again. And there's a nice reminder here that it's not just, support from the beginning at any point across that patient journey, from preliminary diagnosis through recovery. There is a need for that support. It's seldom met. And I think we also need to remember that our caregivers also need support throughout this journey. So I don't know if anyone wanted to add anything here.
When I see my patients, I typically talk to them and their family that are with them. And I say, look, you're the patient, you're the one that's diagnosed with cancer, and you're obviously dealing with it in this way, but it affects everybody in their life, right? Their spouse, their children, any of their relatives, any of their friends, because now they all have somebody that they're worried about. And so they don't have the cancer, but it affects them just as much. And really open that door so they all recognize oh, hey, it is a bunch of us. And be able to talk about it and sort of just help, because I feel like sometimes the caregiver doesn't know what else to do except for focus on the patient, and then the patient gets annoyed. They're like, oh, she just sits hanging over me the whole time, she's always nagging, are you okay, what's going on? And I sort of play a little bit of a therapist. We're well, that's because that's all they know how to do, is how to care for you that way. So look at it in a positive light, but really just explore that option for all of them so that they realize that it's pervasive throughout their family and their support system.
Elliot, did you have anything you wanted to add here?
No, I think, I'm going to leave it to the experts who are actually dealing with patients, but thank you.
Great. Dr. Wendling?
Yeah, I guess, Dr. Wilson covered the majority of it. I would add that I would say in the last 5 to 10 years, we've made great inroads in the ability for us to have very open and transparent and very necessary conversations about, support, any barriers, any mental health concerns or symptoms. And I think, that support is very critical to the outcome that I mentioned previously. So I think this is an area, again, where an employer can have a huge, make a huge dent in things. Because keep in mind, you have your employees, if they're full-time, for a good, third of their, probably half of their awake life. So, they become, their human part, the human and sort of medical parts of their lives don't go on pause when they enter their workplace. So, in my practice, I've always been very open, with my patients, and I think it's a real step forward, and it's an important role for the employer.
Great, thank you. Again, I think it's good to highlight just the amount of wonderful support available from our local community and our local hospitals here. And then getting into this, I think what I was really excited about when we received this grant and had the opportunity to take part in this is how easy they make it for employers to have takeaways from this. So we're using a bit of the National Alliance's lingo here, but when we say purchasers, we're also talking about our employers, basically our purchasers of healthcare, our employer members as you're purchasing them. This Just Deck gives a lot of information in each section on things that you can work with. So this is ways to help your employees and your members who are maybe dealing with cancer. It's gonna, highlight those specialized support services on the right side, and it's gonna give you just a lot of takeaways that you can do. So what they, are talking about here, identifying and assessing the support that your health plans provide. So that's just the number one thing, talking to your plan, learning what that they do. And we're not just talking about your health plan, we're talking about your EAP, about your pharmacy, about disability, all of the different components of the benefits you provide to your employees. Identifying what support programs are available for those members that are newly diagnosed with cancer. So it might be case management, the additional psychosocial support, funding, peer support, medical review, and then also learning if there's an additional specialized case management for cancer care. So they have nurses specially trained in oncology. Are they doing shared decision making, offering symptom management support, and the coordination or care or case management that we often see. When we see this term specialized case management, is there anything that employers need to know that differentiates that between the typical care management or case management they might be used to receiving through their medical? Dr. Wendling, you're not on mute. I'm going to throw it to you first.
Yeah, so a couple things about cancer-related case management. This is likely the highest specialized form of case management that we have, and most cancer providers, provider networks like St. Luke's and Lehigh Valley, have care navigators that are part of the team that works with the patients. So really, they get to know these people really, really well, and they're almost like with them on their entire journey. The other thing I will add is that, a lot of times, depending on the payers often have and will have an expert as well. So this is, one of those things where when you're looking at, your particular insurer, it's something to consider, what kind of care coordination they offer for this kind of thing, because it really does lead to the best, most value-added outcomes and the best journey for the patients. I don't know, Dr. Wilson, if you have, more to add from your.
Exactly like you said, both of our health networks have our navigators embedded into the care team. But I have had some patients have like a nurse navigator or something through their insurance, who then also follow up with them too on periodic basis, depending upon what treatments they're getting. And it just adds another level, because sometimes they just get them in a different environment. They start talking to them, and like a patient will come in and say, oh, well, my nurse navigator told me I need to talk to you about X, Y, or Z, because maybe they feel like they can open up to them in a different way. So, there certainly is an entity in some of the insurances and the coverages. And I think it adds another layer of support.
Yeah, and absolutely. I will say that, right, the whole role of navigator has really evolved tremendously. I mean, it's it kind of started in the breast space, but it has certainly expanded outside. The other thing that we've seen is, programs starting with navigators as early as kind of the screening process and early detection, because, so it's, and helping people get to that next step. to make sure that there's a good continuous flow of care. And so that's very different than, at least when I worked in kind of the employer consulting space, where a lot of the case management was much more about preventative care and kind of working with diabetes management and heart management. I mean, this is really making sure that these patients get the best possible quality of care to ultimately get the best possible quality of outcomes.
Great, thank you. And again, I just like how it's all tying back to, the importance of support, but also that we're covering that patient journey throughout the cancer diagnosis and treatment. We do have another poll here for the audience. So it should be popping up on your screen in 1 second. And this is just asking you about the programs available through your organization or your health plan. So the poll is up on the screen. Let me give everyone just 5 more. Oh, it is a multiple choice, so I realize I need to probably go a little slower. You can choose all that you want. We're asking about case management, psychosocial support, funding support, peer support, medical bill review. Again, none of the above are unsure, don't know. So we have a little over half responding. So I'm going to share the results now. So pleasantly surprised that people seem to know some of the supports that are available, and case management is definitely up there, and a little bit surprised that we're seeing more of the psychosocial supports. I feel like those are sometimes a little more hidden. So it's good to know that our organizations and our health plans are providing them. And again, for those of you who say unsure or don't know, remember the whole point of this is learning about takeaways that you can take back. So this is something you can go back to your health plan and you can pull out this piece of paper from the presentation and say, what do you do related to these? So it's meant to also be a little bit of a roadmap here for you. Just going to tie out the support services questions. So these are questions for our employers to ask their health plans, but I also just thought we would spend just maybe a minute or two here doing a little round robin, kind of for you to focus on anything maybe you haven't shared yet. And really the takeaway here is, what can other employers do? So when you think of yourself as an employer, how do you do these things for your members? But then also, the big takeaway, how do we make sure that these support services are in place before they're needed? Dr. Wilson, do you want to start?
Yeah, so I think it's really just important to think of everything as a whole, and sort of how would you approach care in a patient, and sort of from a stepwise fashion from the intake of the patient, throughout the journey, what steps are at each way in terms of, because there is a bit, we didn't talk about it a little bit, there is a difference between active treatment and surveillance and survivorship, and each one of those components may need something different. So kind of finding out what support systems are in place for each of those journey, each of those individual journey pieces for the patient.
Dr. Wendling or Elliot, did you want to add anything here?
Amanda, I'll just add that, the importance of that, of the engagement, I think, of the patient and family, and sort of making sure that the patients are taking advantage of everything that's offered them. I think, one of the big things that I don't think has been mentioned yet is the more involved and engaged the patient and the family are in the treatment, and the more goals they set for themselves, the better their outcomes are overall. And I think, cancer treatment is really probably the most complex to understand, and has so much variation inherently. So, keeping that sort of openness and keeping that support, present throughout the entire process is very critical to how things, what kind of outcomes the patient has, but also how they experience the journey of the illness.
Yeah.
Yeah, the only thing that I'll add, and look, obviously I'm kind of at arm's length from any sort of patient interaction, but really, what I've seen is kind of how this kind of follow-up and care has moved kind of from more of a siloed and segmented approach to much more being kind of a multidisciplinary, interdisciplinary approach that really is taking the holistic concerns of the patient, basically from diagnostics through to, kind of all care. So, and it's really, it's really great to see, and certainly the outcomes for it kind of show the benefit of it.
Great, thank you. I'm also going to add for our audience, please remember you can submit your questions through Q&A on the toolbar. So please do that if there's anything else you'd like more information on these sections. We are going to be jumping into the next one, confirming diagnosis and stage. We have a little bit here, but we'll get into kind of the more detailed second opinions and biomarker testing. Just a little primer information. So really what we're talking about here is the importance of getting it right from the start and knowing how much the disease has progressed to make sure that the right treatment is getting recommended and that the right support is being offered. So just going through this, again, we're getting into that caregiver support. We're circling back on that case and care management. We're going to get into the other areas in more depth. So just going through here, this presentation also has some great patient resources. So things as employers you can share with your members. This one comes from the National Comprehensive Cancer Network, but they have some good information on the types of questions to ask after a new diagnosis, really getting the basics going. And we're going to have more of these throughout the presentation. So this is just a little quick poll here. And after diagnosis, does your organization or health plan help patients know which questions to ask when they first receive a cancer diagnosis? And this one, again, it may be a little more opaque to our employers if it's something your health plan is doing. So again, it's something that you can ask about. So we have answers coming in and it seems pretty split, a little over half responding. We have a mix of yes, no, and unsure. And I think just a quick head nod from our panelists on here, does that kind of seem a little bit opaque that employers don't always necessarily know what the health plans are doing in this area? So getting into second opinions. And I think that this is just a good point that they drive home a lot. The best time to get a second opinion is after the initial diagnosis and before treatment. So we want to find out if it's rare, if there's any question of the diagnosis or stage, we want to make sure that that's sure. Again, getting into the importance of having the right diagnosis and stage for the right treatment options. Getting opinions from all of the different specialists involved. Getting the right expertise for those rare cancers and understanding the risks and benefits. So with second opinion, Dr. Wilson, is there anything that you would add here?
Sometimes patients are afraid to tell you that they're getting a second opinion because they're afraid you're going to be offended. And I always tell my patients, I'm happy for you to get a second opinion because, and they're, sometimes their family members are pushing it. And I said, because I'm always happy to learn something new. I would welcome the opportunity for somebody to teach me something I don't know. But I said at the end of the day, they are making the treatment decisions for themselves. Like I can guide them, I can tell them what I recommend, sort of guidelines and things like that. But they, at the end of the day, are ultimately making the decisions and need to be comfortable with what they're choosing. And so I'm always for them getting a second opinion. I never get upset. I'm happy if they, I want them to feel comfortable with their next steps. I do try to guide them to a cancer center, right? An NCI designated cancer center, things like that. Because if they are going to get the opinion, you want them to obviously get, the expert opinion. So, you know, you want to make sure they're going to the right place for their opinion, but I always encourage it.
Yeah, and this is definitely a primer on the second opinions, as it will come up again later in the content related to choosing networks and things like that. Dr. Wendling, Elliot, anything to add?
Quickly, I would just say that agree with everything Dr. Wilson said. I also think that the second opinion, you know, is optimally timed, you know, at the very beginning before that treatment is started, because the treatment specificity, which we will talk about down the line here a little bit, is really important for optimal outcomes and to really outsmart the cancer, so to speak. So, you know, second opinion, though, for really, you know, almost any patient, I think it's almost not an expectation so much as sort of a, I think it's always good to get another point of view and another expert opinion, because you just really want to feel like you, at the end of the diagnostic sort of settlement, if you will, you have complete understanding as much as you can and confidence in the recommended treatment options that you've been presented with. Very important to have that heading forward.
Yeah, I'll echo what Dr. Wendling said. I mean, in the sense that for a lot of patients, obviously, a second opinion is very important, but I would say kind of more important is making sure that the diagnostic workup is complete at the forefront. So there was a recent study that came out in ASCO just this past year, talking about a little better than 50% of the non-small cell lung cancer patients receiving testing on all the 6 major biomarkers, you know, that have first-line therapies attached to them. So, you know, clearly there's room for improvement there. And so whether it's on the first, you know, opinion or the second opinion, making sure that all the facts are known up front.
Great. Yeah, I think that'll also come in again as we're talking about prior authorization and things like that. So a lot of this is important information that does really tie in across the journey, and especially this portion of the journey. So quick little, one more patient resource for you. So again, getting that second opinion early between diagnosis and treatment is important. And another thing is just the question of what is rare. And we're not talking about what Google's definition of a rare cancer is. It's a discussion between a patient and their doctor. How many patients have they treated with this cancer, with this stage of cancer? And if it's not a number that you're comfortable with, it's another opportunity to get a second opinion from someone who maybe has a little more experience. And, you know, when you think of rare and experience of the doctor, it's what the patient is comfortable with. So it's a great resource here again. So going to launch another poll. I do apologize if this takes a second to come up. So identification and second opinions. Does your organization or health plan effectively identify new cancer patients and steer them when appropriate to second opinions? So again, is this an area that's maybe a little more opaque to you as an employer? And it seems like, yes, that is the consensus, that this is not an area that we get as much information on. I have a little over half responding, so I'm going to share the results. So we have at least one person who knows that they are identifying them and steering them to second opinion. So that's great to have that familiarity with what the health plan is offering. But from the majority, it's unsure or don't know. And again, does this kind of seem like the level of opacity that we might kind of expect, that employers are not always aware of what their health plans are doing when we get to these specific areas? I'm seeing a lot of head nodding there. So anything to add before we move on? Okay. We are going into testing for biomarkers. and using these to inform treatment. And Elliot set us up great for this. So we have kind of 2 slides here that go through. And Elliot, I know that this is your background, so I actually may just hand this over to you to give a good intro on.
Sure, and I'll introduce myself a little bit first, just because I'm sure people are only like, who's this guy? My name's Elliot Codner. I'm a biomarker testing account executive for Genentech. Just to be clear, Genentech is a therapeutics company. We are not a testing company. The reason my role and and our team exists is because we, a lot of the therapies that we make are targeted therapies for very specific biological mutations within oncology. And so we understand that, it becomes very important to make sure that patients are appropriately identified, and for those who will get the best benefit from those targeted therapies. So, I guess the thing I always like to say is the best way to win a race is making sure that you're at the start line. So, when we talk about biomarker testing, we're really anchoring to kind of the same definition that recently, like Longevity had put out, which is really talking about the somatic or the driver mutations for any given cancer. So we're not talking about kind of the genetic or germline mutations. It's really what is driving that specific cancer. So we'll say 10, 15 years ago, people, cancer was really more about the anatomical origin. So you have breast cancer, you have lung cancer, you have gastric cancer. Now what we understand is that there's very specific mutations that are driving that cancer. So now you have HER2 breast cancer, but you can also have HER2 lung cancer, you can have HER2 gastric cancer. And in lung cancer, there's multiple mutations that have been identified that really drive that. So hopefully that's helpful, at least to, for the audience to understand what we're really anchoring to, and also understand that when we're talking about this type of testing, a lot of times these testing are what they call companion diagnostics. So the diagnostics that not only identify the prognosis of how a patient would have their outcome would have been in the absence of therapy, but also prognostic in the fact that, also predictive in their ability to actually respond to a given therapy.
Great, thank you. I think maybe when you have the layperson, our members who don't know, are there biomarker testings for every cancer? Is it something that they should at least be asking about following a new diagnosis?
So at this point, I guess I don't know that there's every cancer. Most cancers there are different types of testing. So there are kind of single gene testing when there are few, kind of a very specific biomarker. However, more and more there is kind of these larger broad panel testing that are taking into consideration and trying to understand both the somatic aspects of that cancer as well as the genetic aspects. So how that patient may respond to therapy, or if there's specific things within a patient's given genomic makeup that would somehow influence how they'll respond.
I'm going to flip forward to our next slide too, because I think that talks a little bit more about tying in these tests with the treatment. So Dr. Wilson, when you have a cancer patient who's newly diagnosed, is kind of just reviewing with them all of the different kind of diagnostic tests, is that kind of the normal? And are there, occasionally on the patients to kind of be looking up and asking for these? Do you see like differences across, the country even?
Yeah, so I'm a melanoma specialist, really. So I see a majority of my patients are melanoma. And I think there is a split between the patients who are very health literate and those that are not. So, you definitely have some patients who come in and know what they're already talking about and tell you that, they want testing for certain genetic mutations, things of that nature, and they want certain treatments, or like, hey, I heard about this treatment, that treatment. You know, and then there's some that are just don't have an understanding, and you sit there and explain to them what it all means. And I do send genetic testing on any patient who is high risk, who we're contemplating even giving some type of treatment, whether it's preventative treatment versus treatment for active disease. Those are the patients I was like, if they're getting treatment, they're going to get their genetic testing sent. I will say there is a variation in coverage for testing. It's not uniform, despite the fact that there are known genetic mutations that could be targets for therapy for melanoma. And I suspect it's like that for other cancer types as well, because there are some cancers that there's known genetic mutations that you will target before you do certain types of treatment. And I know there's a lot of work being done to standardize the testing for these, and, you know, essentially reflex testing through pathology to make sure it all happens. Because as both, you know, as Elliot was saying and Dr. Wenley, these are important factors to know ahead of time before you start moving forward, because it does make a difference what you're going to do with a patient.
Great, thank you. I'm going to jump ahead to kind of what our purchasers can do. So appropriate use of biomarker testing, ensure the plan design covers the biomarker testing to guide the appropriate therapy, ask the plans the guidelines they're using, ask the plans to demonstrate their monitoring is consistent with these guidelines, and development of blood tests, monitoring this to make sure they're identifying multiple types of cancer with one test. And Dr. Wenley, I thought I would send it back to you for some follow-up, because I know you have a lot of experience with network development and working with health plans.
Yeah, so one of the things that Dr. Wilson said, well, all of the things she said were very informative, but her point on the payer side is incredibly important. So even when the evidence is particularly when it's new and it says doing X related to this specific biomarker leads to better outcomes, the payer may not cover it. Now, there's a couple of reasons for that. One is coverage always lags behind evidence, always does. Two is when things are very expensive, it also lags even more because, you know, plan design has to take into account costs, and actuaries have to model out, you know, costs and outcomes. And you know, there's so much variability now in terms of how health plans set up their cost structure, that, you know, that also takes a lot of work. With that said, you know, this is a very, very, very differentiating thing. As Elliot said, I mean, so I graduated from medical school in the early 90s. We didn't have any of this. And a lot of cancers like melanoma, people actually couldn't even tolerate the treatment a lot of times. What is very unique about some of these biomarkers is not only are their outcomes, you know, often very differentiated and better, but the tolerability of certain treatments is much better as well. Now, sometimes there are side effects that are limiting, very limiting. You know, ones like diarrhea and rashes and things like that. But this is an important area to really look at because, you know, the testing's expensive, the treatments are expensive, but the outcome differentiation can be very significant and substantial. Dr. Wilson's line of cancer care is a very good example. You know, melanoma, wow, metastatic melanoma has really undergone quite a renaissance in the last 5 years. Just as an example, and that's one cancer, right? So same thing can be said for, you know, breast and lung cancer has been stated. Non-small cell lung cancer, that's a big one. So, and I think the setup of how, you know, the health plan really engages that is also important. So that's a very, that's a role that you can play. Keep in mind, I think Amanda showed that it was what, 12% of the total cost. It's more than that. And it's going to be more than that because of, you know, the treatments and the testing that we're talking about.
Yeah, and Amanda, if I can add to this, so
Absolutely.
you know, so all testing is not the same, and so I think I had mentioned earlier that you can do single gene testing or you can do a broader panel, but you have to remember that the tumor sample in and of itself is not infinite. So, and especially as we're doing more screening and finding patients who are earlier, you know, there's a limited amount of sample material. So, you know, generally being able to do a broad panel test, which, you know, both Dr. Wilson and Dr. Welding, you know, had said, you know, the coverage on that really varies tremendously by payer, but being able to interrogate that tumor and get as many answers as possible becomes really important, not just for the ability to treat the patient today, but in a lot of cases, patients will progress. And so the ability to interpret and understand how they may progress and what the next therapies are, as well as, you know, there's, so something, the amount of, you know, oncology drugs that are in development that have a companion diagnostic has basically been growing by double digits each year. So this is absolutely the future. So being able to get these patients into a clinical trial, and something like 20%, 25% of actually oncology patients are involved in clinical trials. So it's not as experimental as much as this is kind of more the standard of care that is, you know, and really reflects how much is being developed and how quickly this is all changing, you know, right in front of our eyes.
Great, thank you. Again, I think we're getting a lot of good primers here too, because this all does tie together. We will be talking about prior authorization. We will be talking about clinical trials. So there will be more to come on these areas. So just going to launch another quick poll. Does your organization or health plan cover biomarker testing and related testing in a manner consistent with professionally recognized guidelines? And again, for those of you saying unsure, don't know, remember the whole point of this is so that you have something that you can use going forward to go back to your health plans to learn more about what's being provided and do some next steps with the cancer care that you provide. So again, don't want to take too long on these. We have about half of our participants responding. And again, it is no and unsure, don't know. So that's kind of consistent with what we're seeing about the understanding of what the health plans are offering or how transparent they are being. So from here, we're going to go into our next section on network selection. And this, we do have one polling question just to help start this discussion a little bit. And this is just going to ask about the types of cancers that you've seen at your organization and use like about the last 5 years, but in recent memory, are you seeing more common ones, breast, lung, colorectal, prostate, skin? Those are kind of considered our top 5. Do you not know? Do you see any of those complex or rare ones? And again, that might not be something that you know. So we have about half. So I'm going to share the results so that our panelists here can see. So we are seeing common cancers. Again, a group saying onshore, don't know. They might not be getting that data from their health plan. One group that has not seen any of them. So hopefully they're not having any cancer cases. But I think this will help guide our discussion because as we get into networks, as we talked about with the second opinions and things like that, it's really important to know what to do based on the types of cancers that we're seeing. So this is really where we start. And it really talks about, you know, something that is very applicable to our area, that you're generally looking at your local care and having regional backup. So most common cancers can be treated by local specialists. And again, I think we have a great depth of local specialists here in the area with experience and training, with the guidelines for treating these cancers and having relationships with centers of excellence and other specialists. So talking a bit about centers of excellence, and this is maybe where I would hand it off to, would either of the doctors like to start off talking about centers of excellence? No. Is this something, do either hospitals work with centers of excellence?
Yeah.
Yeah, I'll start, or go ahead, Melissa.
No, go ahead, you can go.
So my primary job now is running our provider network. So setting up networks is an important part of my life. I think centers of excellence, I mean, we're lucky in this region really to have both St. Luke's and Lehigh Valley here because, you know, both have tremendous cancer networks and have tremendous levels of specialization. With that said, there's certainly, and you know, there's different ways that, you know, centers of excellence are defined and how that definition is achieved. And maybe Dr. Wilson will talk a little bit about that. What I would say is, how does one investigate a care network in terms of, you know, what its abilities are? And I think there are some attributes that are presented in this model that are important to look at. Do they offer, you know, everything that we're talking about? The screening, the biomarker testing, and the treatment. There too, the care coordination. Do they have multidisciplinary treatment? Do they have tumor boards? Do they have? So there's a lot of aspects of, you know, comprehensive cancer care that a network should have when it's treating cancer. With that said, there also should be, you know, a relationship with an NCI designated cancer center. We work a lot with MSK, Memorial Sloan Kettering, and I actually vice chaired our IRB and reviewed probably a bazillion trials on just one cancer treatment, which was bevacizumab, brand name Avastin, was one of the early drugs that was very targeted against a specific form of cancer. But it was actually went through, you know, testing for everything. The point here, I think, is to really make sure that, you know, the network does have that sort of second level offering. I think it's very differentiating. And the cancer networks actually often work very, very much together. They work in concert. So you can actually get the treatment recommendation at your NCI center, and it can still be done locally so that patients aren't traveling unnecessarily. And you know, that also sets up the treatment protocols that are offered to the patients. I don't know, Melissa, if you want to add.
Yeah, sure. So like Dr. Wendling was saying, there are different definitions and I guess levels of center of excellence. And, you know, I would argue both Lehigh Valley and St. Luke's are centers of excellence in our area. We have comprehensive cancer care. We are COC accredited. We have tumor boards. We participate in clinical trials. So I think, you know, the two networks in the area are very well poised to deliver this care to the patients because a lot of patients don't like to travel. So really investing in these infrastructures and the care delivery so that patients can get this in the community. But then I do think it is important to have a secondary affiliation in case, it is, things need to be escalated to what we're not able to provide. So, we have a relationship with Fox Chase Cancer Research Center down in Philadelphia. Lehigh Valley has their affiliation with Memorial Sloan Kettering. So I think we are able to provide care here, but we have our affiliated partners if we're unable to.
Yeah, the only thing I'll add about this, and right, right, so both systems are affiliated with kind of great cancer institutes, as well as St. Luke's has a relationship with Geisinger. I mean, there's a lot. I mean, I do think that while maybe historically centers of excellence and having that designation was much more important, I think what we're learning, especially in a digital age, and kind of that it's much more, it's having these relationships. And this kind of, I think, maybe touches back on that whole second opinion, that we had touched on earlier. Right. So what is their ability to kind of work within a network and have, kind of bring in that expertise? And luckily, and I think we're learning a lot more because of COVID, the ability to do all of this digitally, so it's easier on the patient and still they're getting this top quality care.
Great, thank you. I have to say, I think of all of the content in this deck, this is probably the most complex part. I have to kind of laugh that this is the kind of patient resource and helping to kind of make sure that their network or their doctor, and what it's really talking about is, the selection criteria goes beyond just that certification as a center of excellence in oncology and kind of all of these things to look for. And I was just like, the amount of letters here, am I having a bowl of alphabet soup? But they do a good job for our purchasers. So they come here and kind of this, I think, really does help to make it all a little bit more clear, again, of the things you can ask your health plans about and get more information on. So it does take a little bit of that complexity out of it. We're not so much looking at all of the different credentials, but really, making sure that the network is tailoring to these cancer specific factors, asking about that criteria beyond just board certification. How do they choose their network, their oncology partners, things like that. Getting those specific outcome measures and services. I think we all like to know that there's all of these letters that go with something, but really, what does that mean? What are the quality measurements we're getting? What type of better outcomes are we seeing? Making sure that they're communicating that. So having the plans demonstrate the quality information that they're sharing and that they're displaying in the directories to help patients make those choices, making it easier for the patient. And then again, those procedures, for kind of, is it a complex case? Is it something routine? And we're just looking to get a second diagnosis, a second opinion on the diagnosis and stage. So I really do think that this kind of takes all of that complicated network alphabet soup information that we got, which is very important, but can be very hard for kind of individuals to utilize, and puts it into a way that the employers can really help make good networks available for their patients if and when they do have a cancer diagnosis. So we don't have too many more polls, but we are just going to launch one here. And this one is about what networks are offering. This is a select all that applies, so I realize I will give people a couple extra minutes to choose. It's which of the following does your organization review related to your health plan networks? So that they're tailoring the networks to the cancer specific factors, that they have criteria to select their oncology networks, reviewing the specific outcome measures and services, demonstrating the quality information in the directories, the procedures for those complex cases or second opinions. Again, none of the above or onshore, don't know is an answer. And I do actually have another prompt here for you. If you would like to share with us, if you are kind of reviewing these things, do you have a way that you communicate this information to your employees and members? Is it something you let the health plan do, or do you do something above and beyond to communicate it? If you like, you can put that in the chat or in the Q&A box. We will see it in either place. So we have our participants, and it looks like we maybe have one plan that's kind of doing a little bit of everything, and for the rest of it, we're not really sure. So again, good follow-up here of things to go back and learn more from your health plans about. So, treatment plans, the next session that we're going to. So importance of using evidence-based guidelines is one of the support parts that comes up again. So talk about where most treatment plans come from. We have the National Comprehensive Cancer Network and the American Society of Clinical Oncology. So would anyone like to jump in and talk about just kind of that importance of using the evidence-based guidelines and the role kind of the health plans and things play? How does this play into cancer patients' diagnosis and treatment?
I'll start, I guess, on this one. And I think Elliot was kind of he was at least hinting at it if he didn't express it directly. So the first thing to keep in mind is it's a very complex, area of treatment. So with complexity comes possibility of mistakes, errors, sometimes can happen. So the first thing I'd say is not just important that they're applying the evidence, but it is also important on how they apply it, right? So the systems that are put in place to make sure that things are done optimally. So one of the things that we are, and it's been alluded to a couple times, we're using a lot more data, we're using a lot more, we're actually studying the ways in which we take care of our populations to make sure that we're doing a better job doing so. So, the reliability of the care that one gets with any cancer should be continuously going up. And that should honestly lead to some value on the back end, meaning there should be some, if one does it well, some ultimate cost reduction if that occurs. With that said, just to back up, very important to follow the evidence, but also very important to make sure that the system that's providing this care is incredibly reliable. And, I think we have that in certainly in the Valley, but even organizations like ours are continuously looking at ways to improve that delivery. And that's, the other part of my responsibility in my job is to look at areas of improving the health of the population. So I would highly recommend that, people, as employers, I think one needs to remember that this is a very complex topic on patients that often don't have optimal health literacy. So keeping this, as understandable and digestible for the patient so that they can, give informed decisions, not just informed consent, but make an informed decision, which is another level of comprehension. So I'm going to stop talking about this because I could for the entire day, as certainly Amanda knows, but, evidence-based treatment is one thing. Evidence-based delivery and data-driven delivery is another step. And I think, both organizations in the area are certainly doing that, as I understand it. So.
I agree. It's always a moving target, right? As newer treatments are being brought into the clinic and new data is acquired and new clinical trials and things like that. I do think, there are sets of guidelines that really do help to, a physician to choose optimal treatments, right? And it may not be just one, there might be like a couple, like Dr. Wendling was saying, based on the patient and their performance status and how they're doing and things like that, and like what other comorbidities they have. And NCCN and ASCO have are really the two big guidelines to use. But then we also have to recognize that there's going to be deviation from that based on the patient themselves and based on their what their health is like and what they're going to be able to tolerate and sort of the decisions that they make in terms of like what side effects are they willing to potentially get, versus the benefit of the cancer treatment that they're going to get. There are some, I can't remember the name of it, at one of my former institutions, they had a set of guidelines that was implemented in our treatment protocol, our treatment paradigm, and you had to justify, they sort of gave you, like, if you put in the characteristics, they popped up a couple different treatment trees, and you sort of had to justify which one you are choosing based on all that, and that took into account cost of treatment, patient characteristics, and obviously you can never capture all of it in a form and other things. So I know there are some networks that use these protocol-driven care delivery models. And I don't necessarily know if that's the exact way to go, because I do think at some point you have to trust your clinician that they're picking the right option for their patient. But the guidelines are needed, but then understanding the deviation from them are important as well.
Yeah, I couldn't agree more. I mean, the guidelines are just that, they're guidelines. I think it's been well stated. These guidelines are changing constantly. The treatment, I mean, we were earlier talking about non-small cell lung cancer, up until 6 months ago, all of that treatment was focused in the metastatic setting. It is more recently moving into the early non-small cell lung cancer setting. And so now it's not just the guidelines of treatment, it's also what are the guidelines of testing and what are the guidelines for the surgeon, who is performing that biopsy or that resection, and how is that team working together. So while guidelines are great, it's really important to understand how that system is using the guideline to inform their decisions and how they're internalizing it throughout their care team.
Great, thank you. I see we are coming up. We have about 15 minutes left and we still have a bit of content to get through. So I'm going to highlight on a couple of pieces from the National Alliance and then allow us to get to some other discussion points. So one thing they do talk about is the concept of shared decision-making. They have found that it's a good idea, not always offered though, and instead of just informing patients to give consent, really involving them in the process to make the decision about their treatment plans. I think that really reflects back on what we've been talking about. We've talked a lot about kind of health literacy and things like that. So here is a great patient resource following kind of diagnosis. These are just some of the general questions. There's more specific resources available from the American Cancer Society, Cleveland Clinic, to name a few. But these really help, someone who has a new diagnosis go in there and have some questions to ask. I know in my own experience, nothing is more frustrating than finding out a family member has been to the doctor and come home and ask their registered nurse daughter a bunch of questions about the things. I'm like, why didn't you ask your doctor that? And here's a list of things. So I think whenever we can help empower people to ask the right questions kind of ahead of time, and maybe not come home with all of those, or make them comfortable to know that it's okay to call the office back with additional questions, get the nurse on the phone or the doctor and really go through them. We're going to skip a polling question here because I think what we've learned is that there's a little bit of opacity about what health plans are offering and how familiar the employers are with them. And we're going to talk a little bit more about these best practices later. So we're going to jump into prior authorization here. So really the big focus here is making things timely when it comes to cancer. We don't want people waiting on treatment. So our patients certainly are going to feel the urgency to move ahead with treatment as quick as possible. So it's important to educate about the appropriate testing, second opinions where appropriate. And costs are high. So typically prior authorization is going to be in place. So we kind of have these two needs that we're balancing to address costs, but also to get timely care to patients. So there are some guidelines for what cancer care turnaround should typically be with these prior authorizations and things about delays. So anything you would want to add about prior authorization that our employers should know or should be educating their members about?
Yeah, the thing I will say is, look, make sure that prior authorization is doing what it's intended to do, which is to reduce overutilization or unnecessary utilization, but it does become a problem where it interferes with care. And matter of fact, more recently, there was in California, they just passed new legislation to limit prior authorization on biomarker testing because they recognized that that was becoming an unneeded encumbrance upon patient care as opposed to doing it what it really wanted, what it was really intended to do. So, so that was just for kind of state-run plans, not ERISA plans. But again, what you're starting to see is a lot more legislation, and especially around testing. There was a recent bill in Illinois kind of guaranteeing biomarker testing. So again, it's, I understand why people are concerned about costs. I certainly was a healthcare consultant for a large group plan years ago, but at the end of the day, it really is about patient outcomes and making sure that you're getting the best quality of care for the dollar spent.
Okay, thank you. I'm going to jump through a couple more of the slides here. So they specifically talk about chemotherapy because it is very common within our cancer treatment, and it's also a large driver of cost. So, the IV infusion is really driving that cost. There's both the drug and, those facility charges or staff charges. So there's some guidelines here kind of helping plans better manage and coordinate those. So they give some examples, bundling the costs or fixed costs for infusions. So those are some guidelines there. These are all kind of part of the prior auth. So things to talk about with the plan to better understand their process, and also some ideas around waiving them. Are there certain physicians whose practices have been consistent? They've displayed that ongoing consistency, so they no longer require prior auth. Do we allow patient-centered medical homes maybe to have the prior authorization waived? Same thing for Center of Excellence, or if they agree to use specific treatment guidelines. So these are just some ideas of ways to kind of, again, balance that prior auth need with the need to expedite treatment. And just jumping ahead to this, so really the key takeaways here for the purchasers are understanding those turnaround times, making sure that they're documented, that they're reviewed consistently, that they're sticking to the standards most of the time. Is that process for the review fair and reasonable, appropriate, and does it minimize unnecessary delays? And also, again, we should be kind of tying things together throughout the journey. So is this prior authorization targeting that case management that we've discussed before? So again, we're going to skip the pool for now and get into clinical trials. And I'm going to allow our doctors to talk a bit about it, but I think we have a good resource here, facts about clinical trials to communicate to patients. More people qualify than are expected. It's really not that fear that people have of being treated like a lab rat. They actually get better patient experience a lot of times is reported. And it's not typically a placebo trial anymore. It's usually a new trial treatment compared to an older treatment. So anything, Dr. Wilson, do you have experience with clinical trials you'd like to talk about?
Oh, I think she may be on mute.
Oh.
There we go. Sorry, I had a hard time getting myself off mute. I do have experience with clinical trials. I've been PI on a number of studies, and I certainly encourage patients to go on clinical trials when I think there's like a benefit, right? So obviously, like Dr. Wendling was saying, 10 years ago, if you looked at the NCCN guidelines for melanoma treatment, the top 10 recommendations were clinical trials, right? We didn't have really good standard of care, but we do now. And so now what we're looking at is, can you even improve on standard of care? So I think when patients, certainly some patients are more motivated to go on trials than others. But I think there's every reason to offer patients trials when they fit the criteria, and there's a potential benefit, like there's a benefit to them. I mean, that's the reason to do it. And sometimes that is, hey, do we have something even better than our standard of care? So it's like you're going to get standard of care plus something that may make things even better. There are certainly other times where you are doing clinical trials after they've exhausted all standards of care, and that's just as important. And, explaining to patients, look, there's a scientific reasoning and rationale why I think you could benefit from this treatment, and I really think you should consider it. And I agree. I think they've evolved over time and they've improved over time, in terms of what we're offering patients, and, less likely a guinea pig, more like, hey, this is a potential, treatment option for you. And I agree. I do think sometimes they feel, more engaged because they're dealing with a whole bunch of people from the clinical trial team, from the coordinators to the nurses, to the doctors, to the infusion center. So they have all this like extra care that's being built in. They have this extra attention. And I think and in some ways it helps them, right? It helps put them at ease. They like their team. They're excited, and they feel part of the team that's taking care of them. And I think there are benefits to patients, and, and again, it allows patients to continue to get care where they've been getting them and not having to be referred to, other centers and other places.
Thank you. Dr. Willing, did you want to add something?
Yeah, so I'm a rare bird because I've actually been a participant in a clinical trial myself. And I was an IRB chair. So I've seen all sides of this. What I will say is, as a participant in a trial, you're exposed to a lot of things in a sort of a repetitive way. So you do get engaged with your illness, which has huge value. And I think Dr. Wilson's right. Patients do benefit, when they're in a trial, if only for that reason. They also have the other reasons which she mentioned. I also think that, and this is borne out by some research, there should be more, is that the reasons why clinical trials often underreport some side effects is because a lot of the people in clinical trials are like me. They're not an average patient with average health literacy. There's a lot of nurses in clinical trials. There's a lot of medical people in clinical trials. And I think the more we get, for all types of treatments and all types of illnesses, sort of quote average people, whatever that looks like, for a given cancer and a given illness. I think that's important as well, because we tend to see for certain clinical trials that there are side effects that may not have been reported at a level where it really is. And there's lots of examples of that, not so much in cancer care as much as in other clinical trials. But, I think it's a huge asset to the patient, particularly, in the situations that Dr. Wilson mentioned.
Okay, great. We're coming up on our last couple minutes here, so I'm going to ask if anyone has any questions for our expert panelists, please put them in the Q&A. I'm going to flip through, again, this is kind of the summary of what the employers can do. We will be sharing all of these slides. You'll have this information to follow up with your health plan. We've talked a lot about the clinical trials and everything. I'm going to review disparities and then turn it over to our panel to make their final comments about it. Really, when it comes to disparities in oncology care, we're talking about things like increased prevalence among certain groups of people, or perhaps worse outcomes. So some examples here: breast cancer, African American women are twice as likely to be diagnosed And you also might see things like women in rural areas are twice as likely to die from cervical cancer as women in urban areas. So it's not just diagnosis or prevalence, it's also about the outcomes. And these are affected by things like socioeconomic status. It could be racial and ethnic populations that are specifically targeted or having those worse outcomes. We can also see like that we may have improving rates among a certain population while others are lagging behind or potentially getting worse. So there's a lot going on with cancer disparities. I wish we had some more time to talk about it. It will come up in the third module. So this is just, a really quick thing about the different things that cause disparities and how they're being addressed by the National Cancer Institute. So just doing the research into it, clinical trials, targeted programs, and of course, increasing training. So something that's going to come up is about things that are appropriate. It looks like we have a question coming in, but it isn't quite there yet. So let me keep going for 1 minute. So again, we had another cancer patient study, and really what they found is that there are these racial disparities, and the kind of conclusion that they came to that it seems likely due to that lack of representation of physicians who share the same minority or ethnic background as the people they're treating. So when they did the poll, half of the people said it's important to be treated by someone who understands their culture, but then as you dive in, you find that really there's a very small percentage of patients who share a culture with their doctor. So they may never see a doctor. So 3 times as likely to never be able to see a physician who shares or understands their culture. So I think that that's definitely an area that we need to improve on nationwide. It's also important to keep in mind that women from some cultures and some religions may not feel comfortable, or they just may not even allow a male doctor to examine or treat them. So making sure that we have female doctors available and also that we're able to provide other accommodations. So these disparities, again, do affect the outcomes. And it can even be from area to area. So we talked about how inner city may have worse outcomes than someone in a rural area or vice versa. So treatment can really change depending on the different background. Sorry, we have a question coming in. I'm trying to do the slides and also look at the questions. So again, for purchasers, what they can do is ask the plans about how they provide culturally appropriate care. Do they have relationships in place to provide that care to others? So we did have a question come in, and the question was asking the difficulty of HIPAA. So how can they approach an employee with a new cancer diagnosis who's not being forthcoming given HIPAA limitations? And I think there's a lot to kind of unpack there with just the general understanding of HIPAA to start with, but then also kind of some of the employer responsibilities. So would either of you, any of the panelists like to address that?
I think Dr. Wendling is in a better position than myself at this point to address that specifically from an employer standpoint. I mean, I think, on a personal level, it's if you're a friend or not, or where it's coming from. So somehow they found out, right? Because, they found out they have a cancer diagnosis. And I think it's just being as supportive as possible and allowing that the patient and that employee that space to open up to them if they ever feel like they would like to. But from an employer perspective, I defer to Dr. Wendling.
Yeah, this is a great question because it's sort of the question everybody was kind of thinking when we talk about this kind of thing. So here's the reality of this is as it relates to the data that employers get, and employers do get data on the the outcomes from, their payer group, particularly if they're of a certain size. With that said, the specificity of the data that you have should have its limitations if it's appropriately broad, because there are requirements related to the contract and the agreement that govern what an employer, the depth to what an employer is permitted to know. So with all of that said, what I'll say is, in most cases, you probably shouldn't know. Now, however you found out is however you found out. But if the data use agreement is being followed appropriately by the payer and the provider and and the employer data, it should be blinded. With that said, if you're an employer and you have certainly a relationship with the patient, my approach would not be, I would approach the patient or the employee openly and just say, if anything, if you ever need anything, or, if anything, is going on, my door's open. I think it's very hard if an employee knows any aspects of patient, privacy and confidentiality. They know that that can actually be a divider between you and the employer, and probably not the best thing. So this is a very, very complex question, but I would tread very lightly with the employee because, the DUAs on this, the data use agreements, are very specific about what an employer can and should know. So de-identified, data at a certain level is one thing. Individual is a whole entire another one. Did I answer it as well as I could? It's a tough question.
For my health education background too, I think I could even jump in a little bit also. We don't clearly have how the information was provided. And I always love HIPAA being thrown around because not everything is covered by HIPAA, despite the fact that people like to think that everything is covered by HIPAA. It certainly depends on how the employer got the information, because yes, a breach of a data use agreement by a HIPAA covered individual or entity would be a violation, but chatter at the workplace cooler that gets to management is not HIPAA covered. But again, from a health educator background, I think it's always valuable to do educational campaigns. So, and the big thing with how employers handle these things is not to discriminate. So while you should always seek legal guidance and maybe talk to your company's counsel, you probably don't want to approach the individual person, but you can certainly do mailings to all of your members and post things in break rooms, especially if you think that this is an area of concern for one employee. It's also potentially an area of concern for any employee that could receive a new cancer diagnosis. So there's nothing wrong with posting flyers in break rooms and bathroom stalls and sending mailings out. So I think that that's another just idea to help target that. Things that are more educational to the company overall really helps you avoid those discrimination types of concerns. So our content here is pretty much summed up for the day. We tie it all back together with the importance of support going on. We are a few minutes over, but if I'd like to give each of our panelists just the time to have any last comments. So Dr. Wilson, I'm just going to go across my screen. Do you have anything else you'd like to add at the end of today?
No, I think this is a great forum for open discussion. I think that it's important to have, especially, since cancer incidence is growing, and thankfully cancer deaths are decreasing. So, it's an ongoing need for patients, for insurances and, payers, employers to cover this care for patients. So I think this is great, and thank you for allowing me to be part of it.
Great, thank you. Dr. Wendling?
Yes, thanks, and thanks to the coalition and the other panelists. It was great to have the complementary knowledge of all of us, particularly in that last question. Amanda balanced my answer well. So, you know, I would reiterate what Dr. Wilson shared. I mean, the care of cancer, you know, very, very complex illness, very important for the employer, I think, to, you know, when it comes to areas that are, you know, potentially very costly and also very divisive in terms of plan design, it is an area where, you know, you do want to look into what is offered. And a lot of times there's an opportunity, I know, with the insurers to actually speak with representatives from the provider side or the payer side. So definitely take advantage of the opportunity to ask more questions about what is offered and what is not. The content presented here was very, very excellent. It is very detailed and highly, in some areas, very, very complex, but it does give you a really good framework for looking at a very, very complex and costly area, which is at the forefront of a lot of targeted therapy, as we discussed. So very much enjoyed the opportunity.
Thank you. Elliot?
Yeah, thank you. And yeah, I'll echo. I mean, I think it's great that you're, you know, sponsoring this type of program and that the employer groups are really interested in this. I think it's great, you know, and I feel honored to be on with this panel. You know, I will say there has been a lot of, you know, discussion about cost, and having worked in with employers, I understand, you know, kind of the cost sensitivity. With that said, what I will also say is, you know, in my brief time in oncology within the last 5-7 years, you've seen amazing changes in quality outcomes. And so patients' life expectancies and things like that. And I think it's a matter of time where you will start to see not only those patient benefits, but as, you know, these therapies come down, you'll see testing pricing going down, therapies going down. So I think we're at a real inflection point around patient care right now, and kind of what patients, you know, with oncology, which used to be a short death sentence, you know, kind of living longer, progressive, you know, lives. So.
Great, thank you so much. Well, it was a wonderful discussion and appreciate all the feedback. I know we are a little over, so if you need to drop off, please feel free. I will be sharing the slide deck, sending that out to all of our participants. So what we do have here are the summary of key takeaways. So for each section, there are things that employers and purchasers can do, and these just summarize them for you at the end. So related to support, treatment plans, biomarkers, network selection, prior auth chemo and therapies, palliative care and advanced care planning, which is an area we had to skip through a little bit, and disparities. These are all just quick summaries of the things to talk about with your health plans. You will receive a survey afterwards, and we're going to ask you to just give us a little bit of feedback on your key takeaways, where you see opportunity from this information, how you can better work with your health plan to take advantage of these, specific points that you feel make a difference in care for members. And also, if there's more information you'd like, are there pieces that we maybe missed out on this part of the cancer care journey? As a reminder, we do have the third module coming up. It will be on Wednesday, December 1st at the same time frame. This will help us tie together some of the pieces and get into that survivorship, surveillance, or back to work. So thank you everyone for being with us today. And I will also let you know that when you do get the slide deck, the glossary and additional resources are included in here for you also. So thank you everyone. Have a wonderful day. Appreciate our panelists for being with us today. Thank you so much. And thank you to our audience that stayed on. So thank you and have a wonderful day.
Great. Thank you.
Thank you.
Thank you.